Good afternoon. I want to thank you for joining us in the second of a three-part series on fetal alcohol spectrum disorders. My name is Georgiana Wilton. I'm a senior scientist at the University of Wisconsin Department of Family Medicine and Community Health. I'm currently the principal investigator of several state and federally funded projects addressing the prevention, identification, and treatment of FASD. My research has included screening and brief alcohol intervention to reduce the risk of an alcohol-exposed pregnancy. I'm trained as a rehabilitation psychologist and conduct assessments and aftercare services for individuals and families affected by FASD, including adapting alcohol treatment programming for women, which is really the bulk of my passion. I wanted to clear up some housekeeping issues before we jump in today. If you have questions, and I hope you do, please type any questions into the Q&A box you'll see on your screen. And I have Amber in here with me today from the Department of Family Medicine and Community Health, and she'll make sure I don't miss any questions. And if we happen to go long, I have a lot of material, but I do talk fast, we will keep recording so that the entire presentation will be posted online and you'll have access to it in case you have to jump off at 12:30. All right. Just a brief overview. We're going to go over FASD in a nutshell, just a brief review in case not everyone was able to join Dr. Rogowski's webinar last week. Then we'll start in with the implications for women's alcohol and other drug abuse treatment programs. Okay, so what is FASD? There's a spectrum of disorders. It's a group of conditions that occur in people whose mom drank during pregnancy, and the effects can include physical problems and problems with behavior and learning. And just as a reminder, FASD itself is not a diagnostic term. There are several conditions under the FASD umbrella, and it's important to know that there are several diagnostic schema. So what I'm presenting here is pretty much the Institute of Medicine and the DSM-5. So there's FAS, fetal alcohol syndrome, alcohol-related birth defects, partial FAS, and alcohol-related neurodevelopmental disorder. And the newer term, NDPAE, which comes from the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition from the American Psychiatric Association, so the DSM-5. In Section 2, it's listed as neurodevelopmental disorder associated with prenatal alcohol exposure with the associated ICD-10 code F88. And then the DSM included a Section 3 for emerging measures and models, and that's where neurobehavioral disorder associated with prenatal alcohol exposure, also acronymed as NDPAE, was listed, and it has a really wonderfully written proposed criteria for the impairments. So it's kind of our go-to if we want to know what are some of the cognitive and behavioral challenges associated with FASDs. That definition in Section 3 of the DSM-5 is a great review of that. So what? How can FASD affect women in treatment? Some of the potential implications are really deficits in neurocognitive functioning across all domains, visual and spatial, math skills, especially conceptual. So it may not be sufficient to be able to balance a checkbook if you don't understand that to pay $600 rent out of a $1,200 paycheck, that leaves you $600 for the rest of the month, and you have to budget that and process that and make sure that you don't overspend. So that's the kind of conceptual piece for the math skills that we are mostly concerned about. Visual motor integration, information processing, and we're looking at slower speed, and the accuracy may also be an issue. And this might not be lifelong, but we need to really work on information processing and just really bringing ourselves down to the speed of somebody affected by an FASD. Sensory regulatory effects, hyperactivity, and some memory deficits could be expected. In addition, we look for difficulty with abstract reasoning, executive functioning, and this is really related to frontal lobe damage. Poor comprehension of social etiquette, so making friends, keeping friends, appropriate conversations, those are the kinds of issues that might cause a struggle. Understanding social boundaries, they can be very easily influenced by others, which is very important to understand in treatment settings. Difficulty predicting or understanding consequences. It may appear that they didn't think about it, they just did an action and didn't care about the consequences, when really oftentimes they're thinking about it, they're processing it, they're coming to a conclusion of what the consequence could be, but it's not the correct conclusion. So I don't want anyone to think that it's just that these are people who act without thinking. Oftentimes there is great thought that goes into an action, but the wrong conclusion might be drawn. We want to think about concrete thinkers and really saying what we mean and doing what we mean and not being abstract. In our language, attention deficit hyperactivity, impulsivity, and some mental health concerns may all be issues. This isn't a laundry list of an adult with FAS will have all of these issues. Rather, these are the kinds of things that we watch for when we're serving adults who have any of the fetal alcohol spectrum disorders. We have to be concerned about increased risk for substance abuse, comorbid mental health disorders, and social isolation. So for me, this really paints a picture that's familiar to many of us who are in the substance abuse and treatment fields. So what are the implications for treatment and recovery? First of all, disabilities are pretty common in the U.S., and these hidden conditions can affect more than 50% of students in special education. Not always conditions we can recognize and put our finger on. Sometimes they're hidden and we don't see it till it's later in their life. These conditions can also affect up to 40% of clients in treatment. And we do know, the research shows that individuals with disabilities are less likely to complete treatment. So unfortunately, we have to rely on older research here. You can see the 1994 reference. And I continue to do lit reviews and lit searches and trying to find what's new in this field, and it seems like not a lot has been done about this field recently. We have documented that it's a problem, that they're less likely to continue treatment, but for some reason the research line does not seem to have been moving forward. So we have to consider functional limitations when we're thinking about the adults that we serve who have an FASD. So we really can't assume that a lack of progress is the same thing as a lack of motivation, that not following directions means that someone's being non-compliant, that a lack of concentration means they're ambivalent. We shouldn't be thinking that an inability to recognize negative consequences means they're in denial. Again, they may recognize consequences, just not the correct ones. So sometimes the biggest barrier to success is the way that we approach them in our kind of standard treatment process. So we want to start with screening. Incorporate questions regarding disability into the standard screens. Include assessment for prenatal alcohol exposure, PAE. This really should be universal for everyone coming into your program. We've tested some models in Wisconsin of a screening every woman into the point, at the point of intake in any of the alcohol and drug abuse programs. And we're looking at screening and diagnosing a significant amount of women who are struggling with that. We want to incorporate follow-up questions when discussing medical history. And if it's not really apparent, we could ask simple questions. Did you ever have special classes or tutoring in school? Those are questions that most women and men can answer about themselves. Have you ever had problems? And start listing some of the concerns that might be stumbling blocks for treatment. Concentrating, getting your point across, getting into trouble at school. Were you in the principal's office a lot? Things like that. We also want to consider family history and screening. Did mom drink? Is there a possibility the client has an FASD? But more importantly, did the parents themselves have cognitive limitations? How about mental health problems? Do we have to look at some genetic predisposition? Did any family member receive specialized services? Were parents in treatment? Were there social workers who came into your home? Those are questions I ask a lot. Are current memory problems apparent? And what are they attributing those memory problems to? So I certainly don't want to suggest that treatment providers have to become disability experts, but we really need to do our due diligence. Screening does not mean diagnosing. Suspicions do not equal a diagnosis. Rather, what we want to go to is a model to refer to experts for assessment, diagnosis, and modification recommendations. So we want to include psychological assessments, look at adaptive functioning, which is really wonderful about the new DSM-5 is they put a lot of weight on adaptive functioning and weighing it as equally as IQ. So it's not so much what the IQ number is, how do they navigate their day-to-day life, and what are they able to accomplish without help and with help. We want to look at more functional assessments, and vocational counselors and social workers in your facilities can facilitate this process. So finally, let's get to some treatment modifications. We want to look at addressing the needs of adult clients through physical, environmental, and educational, and counseling and therapy recommendations and modifications. So let's start with physical. We want to make sure there is a safe living environment, physically and emotionally, free from domestic violence, trauma, fear, threats, and this includes the treatment setting. Oftentimes when I go into a treatment setting to do adaptive functioning assessment, the women tell me that they felt safer incarcerated in jail or in prison than they do in the treatment setting. And not because of outright threats of violence or fear. It's more of the fear of, it can be, for some of the women, it's the fear of, if I don't do this, I'm being sent back to jail. At jail or prison, they knew that that's as far as they could go. There wasn't the threat of going anywhere worse than that. And so I think that really working from the inside of our facilities to make it comfortable and therapeutic as possible. Focusing on good nutrition, there are some indicators in the research of protective properties of some nutrients. And we don't want to arbitrarily limit diet. I hear a lot of the treatment programs says we don't allow caffeine. And it's interesting to me because, I don't know, do we allow medications for attention problems, Ritalin or something like that? For some people, especially for me, you know, caffeine helps calm me down. And taking caffeine out of my life was going to make things a little bit more challenging. And I think we want to look at these rules that might sometimes be arbitrary and be a little bit more flexible. There is caffeine in the real world, and if we want to help women prepare for living in the real world sober, this would be a good thing to consider. Exercise, activity, sufficient sleep, and these should never be taken away or seen as a privilege, and especially the exercise. We don't get this stuff done, you can't go on the walk, you can't go out tonight, or you can't do this. When that kind of activity, the fresh air, the outside is exactly what our clients will need. And I can't say enough about adequate sleep. Sleep deprivation, we know, can mimic psychosis, but even not enough sleep, just not getting enough sleep on a day-to-day basis, being short an hour here, an hour there, can really affect our behavior and affect our ability to learn. Some of the environmental strategies, we're going to take these one at a time, so we'll go through structure, predictability, level of stimulation, comprehension, multimodality instruction, and repetition. So for structure, we want to look at an organized, safe physical environment. And this is where our clients sleep, where they do group activities and group work, recreational environments as well. Well-defined areas that remain constant. Small number of people. Remove excess clutter or hide it so that it doesn't look like it's a chaotic environment, that it's very kind of put together, neat and orderly. It can really affect behavior. We want really a balance between minimalist and some stimulation, and the trick really is to play around with the environment until it feels right, until you have the desired effect of calm but still ability to participate and stay focused. Predictability, staff, you know, our professionals, a consistent presence, the same counselors, the same staff whenever possible. Consistent routines, alerting in advance of activity change and not just springing it on somebody. Today we're going to do this instead. We're not going to have group. We're all going to hop in a car and go down to the job center. That we want a little bit more preparation for that. Consistent but fair consequences, no names on the board. We always talk about that as, you know, really working on eliminating, which the vast majority of centers have done this, eliminate public shaming. You know, you're not the board of, yes, you made all of your stars this week, you can go to the movie on Friday, to kind of keep that all between the staff and the woman. And consistency between staff, among the staff, is critical. Consistency in enforcing the rules, behavior expectations between first shift, second shift, overnight staff. No good cop, bad cop, and all the weekend people, everyone has to be on the same page and reinforce it the exact same way. That really can cause a lot of confusion. Monitored level of stimulation, be aware of overstimulation, TV, internet use, smartphones, tablets, technology, all the technology that we use to navigate our daily life, and including really a knowledge of what's going on off-site. Know the venues where your clients are going and what's going on, who's going to be there, what kind of environment it is, even down to sound and what food is going to be available. And kind of a constant, not necessarily monitoring, but educating the clients about interaction with the not so positive people in their life, the people who might not be supporting their sobriety. We want to learn and pay attention to anticipate danger signs, giving frequent breaks, redirecting behavior, not necessarily just stopping it, is redirecting it, reframing it. What we want to make sure we're not doing is ignoring it, because we want to acknowledge anger and overstimulation. Even if we don't understand how to help them, it's just to say, hey, I can tell you're frustrated, I'm not really sure what's going on, but I want to work with you to make sure that this day can be as productive as possible. We definitely have to pay attention to retention difficulties. I usually start with shorter sentences, a couple of concepts at a time, at least initially, until I see where their cognitive level is and how much I can kind of toss at them in a conversation. I like to have people repeat information they heard, not because if they say it back to me, I know they can do it, but it's just a different way of learning. They're hearing it one way, they're saying it, but I don't assume that if they say it, they can do it, because oftentimes with people with an FASD, that verbal IQ is higher than performance IQ. So they might be more expressive, have more expressive skills than receptive skills. So for me, the repeating it is just part of repetition. We want to reinforce memory strategies until tasks become routine. You can do that with pictures, with cheat sheets, with directions on a cell phone, things like that. And we want to use concrete language and really say what we mean. Looking at recognizing comprehension difficulties, we may not have a shared understanding. What I mean by that is their understanding may not match our expectations, especially when it comes to the rule books. So if consequences are based on rule violations, more work is needed to assure that the rules are actually understood, not just simply signed off on. And if I could, I would do an entire talk just on rewriting the rule book, looking at contracts, if they've been involved with the justice system, Miranda rights and confessions, and just general questions and confusion. So this is a population that might agree or sign something. I understand the rules when really there isn't any understanding. And it's our responsibility to check in on that and to make sure they understand what's being signed or what's being expected. I want to thank Diane Melvin and Susan Doctor for their really helping the field understand looking at abstract versus concrete. So we want to avoid abstract, the why, wait, listen, clean it up, predict, plan ahead. What are you feeling? Set a goal. How often we require the people that we serve these kinds of abstract activities in their day-to-day treatment life. We want to be more concrete on the right side of the slide. Show me. Come with me. We're going to do it now. Tell me what's hard. What does that make you want to do? Oftentimes we can put our finger on what it makes me want to do when I don't actually understand what the feeling is behind it. Time frames. We have to look at time frames and increase time to complete objectives, whether it's homework, whether it's processing information, whether it's waiting for a response, making a plan, making the bed in the morning. We really want a little bit extra time for everything that they'll need to do until we have a good sense of how long things take. It's especially time for transitions and changes because those are more difficult. Getting up in the morning, to getting ready, to getting into group, to transitioning from group to lunch, from lunch to the afternoon activities, things like that. We want to expect and accommodate that extra time. And again, increased time to process and respond to requirements, especially in a group setting when their mind might be distracted by watching other people. We really need to allow that extra time of information processing. Multimodality, instructions, education, looking at picture cues of tasks and routines, especially if there's an absolute right way or a specific standard that you need them to accomplish. So if it's in the rule book that they make the bed this way, we want to really make sure we have instructions. Let's take a picture of it and post it next to the bed. We could put directions on the cell phone. And we could maybe have pictures that include, this is not the best way to make it, this is what we're looking for. And then also recognize that not everyone makes the bed the right way in the real world or the same way in the real world, and maybe that these are the kinds of activities that we can allow a little bit more flexibility in. But if there is a right way and there is a standard that they are expected to meet, it's our responsibility to make sure they understand that standard and that they're able to do it. I love sensory aids, the list, the tape recorders, the headphones where they can hear things and they can see things. Maybe, you know, with our cell phones now, we can videotape how to make the bed, and they can play it if they need some additional instruction. And number one, I guess it should be at the top of the slide, is it's really important for us to model the behavior. We shouldn't be talking to them in a manner that they are not allowed to talk to us. We shouldn't be joking around and talking with our colleagues at work unless that is what is expected of the women too. Is the way we treat ourselves, the way we treat each other, the way we treat our clients should exactly model what the expectations are. And for repetition, we just really want to make sure we go over a concept or a requirement or an activity as often as it takes for them to get it. And it might be repeating it the same way. At some point, we recognize they're not really getting it. Let's figure out a different way to teach them that, and then repeat it that way until they get it. It might take a while. It might take kind of trial and error, but eventually they'll get it. A couple of cautions here. What we want to watch for, again, don't understand that if a client can repeat it, they can understand it. We've talked. I already mentioned information processing. I really want to pay attention to masking. You know, the kinds of things that clients have gotten really good at. By the time they've come to us, they've spent a lifetime kind of masking their disability and helping to hide it so that they fit in. So things to look for are waiting for others to go first. You know, clue gathering. Are they always in the group saying, oh, that's what I was going to say. She took my answer. Now I don't have anything. Those are excellent and very well planned masking activities. So we want to pay attention to that. We want to put our detective caps on and see what might be going on in the environment that helps them hide their disability, that we can unwrap and help them be able to process and come up with unique responses. I want to watch for idioms. Sometimes we, you know, there's not enough room to shake a cat in here, or Elvis has left the building. And it's not that every person with an FASD doesn't get idioms. Many of them do. But we want to also know have to recognize that they are regional, they're statewide, they're sometimes just, these idioms can be just in our own treatment setting, that they may not be understood by all people if you say, you're on thin ice here, or you're just treading water. You want to continue to watch for reactions, unexpected reactions, to loud sounds, to sirens, to people raising their voice, because that could be a really good to help us understand the trauma that they've experienced in their life, especially things like sirens and the difference between fire engines and police cars. Also, if you're working with dental care, for women who have been traumatized, going to the dentist and being tipped backwards and forced to have their mouth open, and pain associated with that can be a very huge trigger to women who have been sexually abused, and to prep them for getting ready to go to the dentist, to go to the doctor, and hopefully have an advocate there that can stay with them if they need that. We've done a lot of work with dental hygienists around this issue and what to recognize if a woman is getting traumatized or getting too anxious. Again, behavior can be related to or exacerbated by other needs, so we want to start thinking about sleep and sensory issues and consider a sensory diet. Make sure there's enough exercise and there's enough opportunities to get outdoor, and have these activities never be taken away as a consequence. So in counseling therapy, we want to include work all the time on social skills, and this is the area where many people with an FASD stumble and can get into trouble because of misreading social cues. And we've also know, the research is showing us loud and clear, that improvement in social skills has a really broader effect on education, on learning other skills, and fitting in all kinds of environments. So it's definitely time well spent. We want to look at modifying the counseling to accommodate the cognitive disability. These are things we've already covered, so just to know that the same strategies are important in counseling, and to consider the insight orientation of the client. Not all clients can benefit from motivational interviewing, which is very abstract. It relies on very good frontal lobe function, so we need to take that into account. Always choose practical language that's specific to the individual you're serving. We want to be able to put this information into practice and not expect generalization. We want to teach in the real world, and that might mean getting out into the community, taking field trips, looking at those 12 steps and rewording them to be more concrete. You can actually Google that now. They've got, AA has 12 steps for all reading levels, and the lower the reading level, the more concrete they are. Again, if motivational interviewing is your go-to, it's going to have to be adapted for adults with cognitive limitations. So, by way of review, FASDs, which is evidence of prenatal alcohol exposure, should alert you and your staff to a range of potential cognitive problems, cognitive challenges that may need modification. No single intervention is going to be effective for everyone, but we want to be able to do some assessments, even if you don't do it on site, to recognize that assessment should be done to see where they're at cognitively. Not every behavioral concern is directly related to prenatal alcohol exposure. We want to really look at anxiety, stress, sleep issues, and sensory issues. So please consider them in all the clients that you serve. Finished on time. I am happy to take any questions you may have. Amanda's going to help me to be able to see what those might be on the screen. Oh, can I give some examples of social skills that can be worked on in therapy? Absolutely. Social skills is really one of the big things we like to start with, is recognizing nonverbal language. So pay attention to body language, body cues. What does it mean when someone steps forward, they step back, they roll their eyes? If I could design a social skills way to say, this is my opinion only, not necessarily represented by the University of Wisconsin. If I had to develop a social skills curriculum, I would make sure it includes understanding teasing versus sarcasm versus bullying, because there is such a fine line between that. But the whole nonverbal, crossing the arms, and the fact that as adolescents, in adolescence, people rely less on verbal language and more on nonverbal language. And if you don't understand what the rolling of the eyes, the crossed arms, the deep sighs, yeah, right. If someone says, yeah, right to me, it doesn't mean that I'm agreeing with you. It usually means just the opposite, and to really focus on those kinds of things. How to reach out to other people, make a phone call, initiate a social engagement. All those kinds of social aspects should be included. If I had to start with one and focus on one, it would be body language and nonverbal cues that typically go over the heads of people with cognitive challenges. Any other questions? Oh, thank you. It's a great presentation. If you have any other challenge, you can any other questions, you can certainly email me. It's georgiana.wilton@FAMED, Frank Adam Mary Mary Edward David .wisc.edu, and I'm happy to answer questions along the way as well. And we will work to get this cleaned up and posted, and we'll email a link for everyone. So if your audio was a challenge, that you can listen again should you so choose.
Will you be sharing the slides?
Oh, yes, I'm happy to share slides as well. I'm happy to share slides, and I will make sure that everyone who registered gets that as well. And please, we're going to be sending out a link. Lindsay Peterson will send out a link to you with a post-training evaluation. We certainly would love it if you would take the time to fill that out. It's very brief. And next week, a week from today, we'll be rounding out the series with our last webinar, and there's still time to register. You can email Lindsay Peterson, and she will get you registered for that. All right. It looks like there are no further questions, so I will thank you for your participation and hope to see you online again next week. Thanks very much.